In the last session, we have discussed about the classification of cardiomyopathy. Today, I'll be giving some clinical scenarios and also a few MCQs to highlight the important points. So let us start the first case. So this is a 22-year-old man presenting with exertional dyspnea and 2 episodes of syncope during exercise. His father died suddenly at 38 years of age. So from this history itself, you should remember that anybody developing exertional symptoms for a sudden death, you should always consider the possibility of a hypertrophic cardiomyopathy. So here the patient's father had died at the age of 38 years of age. So there is a strong family history there. Examination reveals a systolic murmur at left sternal border, which increases on standing. So in dynamic auscultation, when the patient is standing, what happens? The left ventricular inflow, that is, the input is less, the volume of the ventricle is more, and any patient with a hypertrophic cardiomyopathy, when the volume is less, obstruction increases and the murmur increases. So this is the dynamic auscultation. So you can definitely say that this patient has got a hypertrophic cardiomyopathy. This point is clear. So the possible questions are here. So remember that cardiomyopathy is a disease of the myocardium, structural or functional or structural and functional abnormality. The major types are the dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy. And there is a one more is a arrhythmogenic right ventricular cardiomyopathy. So these are the right ventricular ARVC. So let us look into the hypertrophic cardiomyopathy. The hypertrophic cardiomyopathy usually is a asymmetrical left ventricular hypertrophy. The septum is hypertrophied predominantly. The LV cavity is small. The septum is asymmetrically hypertrophied, and the LV cavity is small. And when the muscles are thickened, there is diastolic dysfunction. So there is obstruction of the LV outflow tract. So it presents something, produces a murmur similar to that of a aortic stenosis. A can get a murmur, ejection systolic murmur. And the echo may show the systolic anterior motion of the mitral valve. Systolic anterior motion of the mitral valve. And this also contributes to the obstruction. So we understood the clinical features, symptomatology of hypertrophic cardiomyopathy. Now let us look in the examination findings. What are the examination findings? So you should remember this can be thickening of the myocardium. So the apex can be heaving or a sustained apex you can get. And here an AS4 is it can be ejection systolic murmur. And murmur increases on standing and valsalva. The important symptoms are exertional dyspnea, angina can occur, syncope and pre-syncope palpitations, and of course sudden cardiac death. So symptomatology, because of the diastolic dysfunction, is present with breathlessness. And the dynamic obstruction leads on to the murmur, which increases on standing. So what are the investigations? Just like any other cardiac problem, it involves the ECG. Echo is the key investigation. If arrhythmias are there, you may go for Holter monitoring and cardiac MRI in selected cases. So what are the treatment? The treatment is, one is beta blocker, second is non-dihydropyridine calcium channel blockade. These are the two drugs which are routinely given. Beta blocker therapy. Avoid dehydration. If there is atrial fibrillation, you have to manage it. ICD in selected cases. And there is a septal reduction therapy again in selected cases. So now we understood the presentation of hypertrophic cardiomyopathy. Now we go to another case. So this is a 45-year-old man presenting with progressive dyspnea. So dyspnea means If it is cardiac, it is likely to be due to a left heart disease failure. Orthopnea and pedal edema. So pedal edema means if it's a cardiac, you have to think about the patient has got a right heart failure symptoms. Echo shows dilation of the four chambers. So you now understand that the patient has got a dilated heart. All the chambers are dilated. Ejection fraction is less than 25%. So this means the patient has got a symptoms of biventricular failure and has got a reduced ejection fraction. So the heart failure with reduced ejection fraction. That is our diagnosis. So what will you consider? So first possibility, if the patient has got no myocardial infarction, no evidence of hypertension previously, no history of any valvular heart disease, the first possibility should consider is a dilated cardiomyopathy. And we know that the dilated cardiomyopathy, here there is a pump failure. Ejection fraction is decreased and the heart is acting like a reservoir rather than a pump. So that is the clinical feature or the pathophysiology that is occurring in the dilated cardiomyopathy. These are the expected questions you have to think about. And we know that cardiomyopathy is a disease of the myocardium or a muscle, structural or functional. So what are the causes? The dilated cardiomyopathy, basically you have to consider two types. One is genetic basis. It is mainly one of the mutation is the TTN mutation. Second, secondary causes. If it is a rapidly progressing, you have to consider the possibility of viral myocarditis. It may be due to drug-induced anthracyclines, chemotherapy drugs can produce. Then alcohol, other toxins can also produce. In the last month of pregnancy and in the next 5 months, you can it is a peripartum cardiomyopathy. So basically, there is a primary and secondary causes for the dilated cardiomyopathy. So causes as mentioned, genetic, viral and inflammatory myocarditis, alcohol, chemotherapy drugs, and one more thing is the tachycardia mediated cardiomyopathy. So now we are going to, you should remember the peripartum cardiomyopathy. It's a very important condition. You should keep in mind peripartum cardiomyopathy. Then endocrine conditions and metabolic diseases, nutritional deficiency, autoimmune disease, sometimes idiopathic. So clinical features we have already mentioned. It's a heart failure with the reduced ejection fraction. They are present with dyspnea, orthopnea, PND, fatigue, peripheral edema, arrhythmias, thromboembolism, and even sudden death. Investigations are almost similar to what we have done for the previous case. We should include the thyroid function test and the iron studies if indicated, but it's mainly for restrictive cardiomyopathy, renal function test, electrolytes, etc., just like any other patient with a heart failure. So now we are going to the management. The management of dilated cardiomyopathy, just like any patient with the reduced heart failure with the reduced ejection fraction, you go for the guideline directed medical management. The four pillars that we have discussed earlier. The four pillars are RNA-AC or ARB. Second is an evidence-based beta blocker, a mineralocorticoid receptor antagonist, SGLT2 inhibitor. These are the guidelines. In addition, there is a diuretics. We should give diuretics when there is congestion. So diuretics are given. Anticoagulation when specifically indicated. Think about the ICD. Advanced heart failure therapy includes the transplantation. So that is about the management of the DCM. Now we go to one more case. A 60-year-old patient presents with progressive fatigue, ascites, and pedal. Echo shows preserved LV function, systolic function normal. So what are the abnormalities? The patient has got a LV function is normal. So LV function is normal by the biatrial. Right atrium is enlarged, left atrium biatrial enlargement. And impaired ventricular filling. So there is a restriction in the filling. So this is a what is called a restrictive cardiomyopathy. So these are the usual questions you should remember. So restrictive cardiomyopathy is almost always due to a medical problem, another secondary condition. The most common condition, remember, is amyloidosis, sarcoidosis, hemochromatosis. So amyloidosis, there is increased wall thickness, systemic features like carpal tunnel syndrome can occur. Hemochromatosis, the bronze diabetes, they develop diabetes mellitus, liver disease, and other features of iron overload. And in amyloidosis, we can get macroplosia and carpal tunnel syndrome. In sarcoidosis, you get multisystem disease, lymphadenopathy, endomyocardial fibrosis. Again, is a restrictive physiology. Radiation can present. Some storage diseases are rare. The core concept is the major abnormality in our restrictive cardiomyopathy is impaired ventricular filling with preserved systolic function in the early disease. The LV function is fairly preserved. Now we go to some short answer questions. So there are four main types of cardiomyopathy: dilated cardiomyopathy, the hypertrophic cardiomyopathy, restrictive cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy. So these are the major types. Now we go to few questions, more short answer questions. Cardiomyopathy is a definition. We know cardiomyopathy is a myocardial disorder characterized by structural and functional abnormality of the heart muscle. It's a disease or this a diagnosis of exclusion or other conditions should be excluded, like coronary disease, valvular heart disease. So major phenotypes we have already mentioned. The mentioned 5 causes of dilated cardiomyopathy. So first and foremost, genetic, the mutations in the DTN, alcohol, myocarditis, anthracyclines, and the peripartum cardiomyopathy. Very important. What are the classical symptoms of hypertrophic cardiomyopathy? They present with the diastolic dysfunction. The diastolic dysfunction, ejection fraction may be normal. They present the exertional dyspnea. Angina can occur. Syncope and pre-syncope, very important. Palpitations, and of course, sudden death either in the family or the patient itself. So, the family history is very important. Why does the murmur of hypertrophic cardiomyopathy increase on standing? Is the usual question. Why does the murmur of hypertrophic cardiomyopathy increase on standing? Standing reduces the venous return. It reduces the LV diastolic volume and brings the hypertrophied septum. We have already mentioned that here there is an asymmetrical septal hypertrophy. So that is one of the characteristic feature. So when the volume decreases, this brings the hypertrophied septum and mitral valve closer. So increases the LV outflow tract obstruction. So this produces increase in the LV outflow tract obstruction. So that is the answer. And you get the intensity of the murmur increases on standing and decreases on squatting. Remember this point. What is the mentioned 5 causes for restrictive cardiomyopathy? We have already mentioned amyloidosis, hemochromatosis, sarcoidosis, EMF, and radiation-induced myocardial disease. So remember, restrictive cardiomyopathy is a disease. Most often there is an underlying medical problem. So now we go to the most important investigation is echocardiography. That gives chamber size, wall thickness, systolic function, diastolic function, valvular disease, and will be. What are the complications of dilated cardiomyopathy? So just like it's a presence with heart failure, arrhythmias, sudden death, endocardial thrombus, systemic embolization, and functional tricuspid. So this patient can develop, there is a there is a ventricles are dilated. So remember that in dilated cardiomyopathy, the ventricles are dilated. So what happens? The valves get separated. So there is a functional mitral or tricuspid. This is a functional. Valve is normal. Functional MR and TR can occur. So these are two numbers that you can get in dilated cardiomyopathy. What are the most important causes for secondary cardiomyopathy? We have already mentioned that cardiomyopathy, especially dilated cardiomyopathy, is can be either primary, genetic, or idiopathic, and plus due to other causes. So let us look what are the common causes secondary. Remember the alcohol. Alcohol is one of the very important. Anthracyclines, myocarditis, it a time span, very short duration. Always think about the myocarditis. Thyroid disease. So hyperthyroidism is important term for hyperthyroidism. The nutrition deficiency can produce. Hemochromatosis usually presents with a restrictive cardiomyopathy, restrictive, and tachyarrhythmias also. What is meant by peripartum cardiomyopathy? It's a form of dilated cardiomyopathy. Peripartum cardiomyopathy is an example. Let's say it's a type of dilated or is a DCM presenting towards the end of pregnancy, last month of pregnancy and the first 5 months of postpartum period. That is it's a type of dilated cardiomyopathy. So now we look into what are the causes, indications for is ICD, consideration cardiomyopathy, implantable cardiac defibrillators. So, secondary prevention after appropriate ventricular arrhythmia and cardiac arrest. The cardiac arrest you can give for a secondary prevention. You can give selected patients with severe LV dysfunction, respiratory optimal therapy. Selected HCM patients at high risk of sudden cardiac death. So these are the important causes. Now we go to the MCQ session. I request all of you to take a bit of paper, answer, attempt it, and then continue with the. So stop for a while.